it is open worldwide, this EUROTOX webinar. And it is for me a very great pleasure to introduce Marc Pallardy, as I've been know Marc since the beginning of our career. So I'm not going to tell how many years we know each other, but really it's quite a long time. Just a few words about the background and the current position of Marc. Marc got a PhD in pharmacy back in 1982 and a PhD in toxicology in 1987. He is for many years a full professor and currently is the head of the Department of Toxicology at the Faculty of Pharmacy at the University of Paris-Saclay since 1997. And currently is also the Dean of the Faculty of Pharmacy at the same university. And is also the head of the team Drug and Chemical Allergy, Immunotoxicology, and Immunopathology at INSERM 996. He has a long history of publication in peer-reviewed journals, almost close to 200 publications, and he's been invited many times, more than 100 times, for presentation in international or national meetings, seminars, and conferences, and chairman. Currently, concerning EUROTOX, is a member of the executive committee and also part of the education committees. And this series of EUROTOX webinar is actually part of the education committee activity. In addition to that, Marc is also a member of the Immunosafety Technical Committee at ESI and also on the ESI Board of Trustees since 2018. Is also an associated editor of Toxicological Sciences, Journal of Immunotoxicology, Current Opinion in Toxicology. So really, it's a very well known in the field of toxicology and in particular immunotoxicology. And of course, if we read here in the first slides, the title of this presentation is Understanding Immunotoxicology. So Marc, thank you, and the floor, as we will say, and like an in-person meeting, is yours.
Thank you very much, Emanuela, for this very nice introduction. So I guess you hear me very well. So the title is Understanding Immunotoxicology. Why Understanding Immunotoxicology? Because I know most of the scientists and the people doesn't like very much the immune system because they think it is too complex, and since it's too complex, they don't try always to understand what could be the consequences of affecting the immune system by chemicals or drugs. So my goal today will be effectively to make you understand immunotoxicology if you don't know immunotoxicology enough. And I will first start by remember you how the immune system is working in a very simplified way. Yes. Move. Voilà. So first, immune system physiology and regulation. So what is immune system? First, it is very important to understand that the immune system is here to clear the danger from the body to its infections agent, cancer cells. It's also important to distinguish self between non-self. It is very important that you don't mount an immune response to your own protein or your own component of your body, because then since it's going to be an autoimmune disease. And it is also important to recognize what is danger, okay? Because you are exposed every day to environmental antigen, and you are not making an immune response to environmental antigen every minute. So the immune system, you will see, is equipped to recognize what is danger, what is foreign, and what is dangerous and non-dangerous. So non-self and danger is very easy. It's microorganisms, it's parasites, it's virus, it's foreign protein. Cells and danger, a little bit more tricky. For example, you have cancer cells. Okay, they are from self, but they are cells that are dedifferentiated and are expressing some new antigen that probably make them understood by the immune system to be dangerous. And you have a normal situation with a non-self and non-danger, the fetus, with foreign antigen from the father. And there is two complementary arms, the innate immunity, which is very quick, it's constitutive, it's immune detection, for example, neutrophils. And adaptive immunity, when innate immunity is not sufficient, then you go to adaptive immunity, which is very antigen specific. So this slide is very, very quick. Immune system is not an organ, okay? It's disseminated all over the body. And you have lymphatic nodes all over the body, as you can see on the slide. You can see there is lymphatic, because the immune system has to be the immune response has to be very, very quick. And if your antigen arrive in the skin, then your lymph nodes will be in the axilla, just in the arm, to react very quickly to the introduction of the antigen. So innate immunity is mostly phagocytosis with neutrophils and macrophages, and are in first lane. You have AGA, for example, to protect the mucosa. You have complement to induce cytotoxicity in some specific cases. And you will see for cytotoxicity, in this case, we have to kill the cells. You have natural killer lymphocytes that can recognize some cells in certain specific conditions. And then for adaptive immunity, this which is antigen specific, you need some cells that are going to present your antigen to your adaptive immune cells, like the T cells. So you need T cells, and you need B lymphocyte to produce antibodies. So adaptive immunity, you will have the arm made by T cell, that will be the cytotoxic T cell, for example, and B lymphocyte producing different types of antibodies. And the immune system is complex in a way that it needs to be adapted to every kind of situation. So you need to have some subpopulation. You have what we call the Th1, more inflammatory, Th2, more in allergy and parasite protection, Th17, Th22, regulatory T cell, memory T cell, different type of subpopulation. And it is very important to understand the meaning of this all this subpopulation, because it is important for this immune system to be very specific. For example, we have recently the story of bisphenol A that has been shown to induce the emergence of Th17 when the animals were exposed during in utero. So the adaptive immune response, in a way, it's very complex. In a way, it can be very simple. You have to understand first, you need an antigen, of course. You need an antigen that's going to be captured by the dendritic cell, the antigen-presenting cell, and then the dendritic cell will process this antigen and will present it through MHC class 2 molecule or MHC class 1 molecule. And this HLA molecule, class 2 molecule, will present this peptide to the CD4 T cells, or through MHC class 1 to the CD8 T cells. And so then you undergo an extensive proliferation of CD4 T cells, from 50 to 100 cells that are concerned by the different peptides. Then you have millions of CD4 T cells specific for the antigen. And these CD4 T cells are very, very important, because they are going to help the CD8 T cells that have recognized the antigen through MHC class 1. They help these CD8 T cells to mature in cytotoxic T cells that will kill the cells that can be infected by viruses, for example. They can kill tumor cells. They can kill cells that are infected by bacteria. But the CD4 T cell will also help the B cells that recognize the antigen in the whole antigen, and to differentiate in plasmacytes that we're going to produce antibodies directed to the antigen. So to what is important here to remember, you need these antigen-presenting cells that are very specific, that very specifically present peptides to the CD4 T cells, MHC class 2, or to the CD8 T cell, MHC class 1. And then you're going to arm the immune system, but you're going to arm the CD8 cells to be cytotoxic to cells that are infected. And you have to arm the B cell to become plasmacytes to produce antibody directed to circulating antigen. So if you affect the CD4 T cell, you affect the whole system. For example, cyclosporine A can inhibit CD4 T cell proliferation, and we all know that cyclosporine A is a very strong immunosuppressive drug. So I'm not going to go in this slide in detail, just to make you understand that this immunological synapse is very, very complex. But now we are more and more playing with this immunological synapse, and this is at the basis of the immunotherapy now in cancer, which is quite effective. And you can play by affecting this co-stimulatory molecule with the CD28 or all the molecule for the B7 family and CTLA4, OXY40 ligand, PD1, PDL1. And we know that by this immunological synapse, you have positive regulatory signal and negative regulatory signal. So this immunological synapse explains you how complex is the immune system to be very specific in terms of recognition and engagement. So for cytotoxicity, very quick, you have the cytotoxic T cells, which are antigen specific, and they will kill the cell that with intracellular pathogen in it. For example, best example is the cells infected by the COVID. You know, for the COVID, during the COVID pandemic, you needed to have a very strong CD8 response to clear the pathogen. So in this case, you have this antigen-specific cytotoxicity, but on the same time, when you have a condition when the MHA class 1 is not expressed because the cytotoxic T cells need to recognize the infected cells through MHA class 1 and the peptide that is associated, when you don't have expression of MHA class 1, because sometimes the viruses are very clever and they down-regulate MHA class 1, or in cancer cells, they're very clever, they down-regulate MHA class 1 molecules to be invisible to the immune system. Then in this case, you have the natural killer cells that can kill only cells that are not expressing MHA class 1. They're very powerful, and so they are here to defend you against the situation when your cells, the somatic cells, are not expressing MHA class 1 molecule. So for adaptive immunity, if you have an antigen, if this antigen is processed and presented, if you have a T cell repertoire, you need to have T cell to recognize your peptide. Not everybody has T cell to recognize all the peptide from all the viruses. We need the co-stimulation molecules to have full activation of T cells. And if you don't have one of these steps, it is not working. Adaptive immunity. But in 1994, Paul Matzinger, which is a great immunologist, make us understand that you need the immune system to understand what is dangerous and not dangerous. And we then had the famous danger signal. So you need for this dendritic cell here that's going to recognize an antigen. If it is not associated with the danger signal, then the dendritic cell will stay in the skin, will stay in the lung, and will not migrate to lymph node, and will not present the antigen to the T cell. So you need also a danger signal. For example, a bacteria, you have antigen from the bacteria, but you have also LPS, a lipopolysaccharide, that they express on the bacterial wall. And so in this case, the dendritic cell understand that your bacteria is dangerous because you have antigen, but also you have a danger signal. And for viruses, it is mostly the RNA or the DNA of the viruses can be recognized by intracellular protein like TLR, the toll-like receptor. And so if you have inflammation, if you have danger signals, then the immune system understands that what is arriving here, it is dangerous, and you need to have an adaptive immunity. I will skip this one because it's a bit complex and to go on. So what is immunotoxicology? Immunotoxicology, it means that you're going to affect your immune system by chemicals, a drug, a small chemicals, or sometimes a biology. So you have different situations. First, immunosuppression. So the consequence of immunosuppression is the emergence of infection, emergence of virus-induced leukoencephalopathy in certain specific case, HIV, of course, but also with some drugs like natalizumab, using in multiple sclerosis. And you also have virus-induced cancer. Most of the cancer that are due to immunosuppression are virally induced, meaning that you have a downregulation of the immune system leading to emergence of cancer that with immortalized cells due to virus infection. You have also inappropriate stimulation of the immune system, and some of you know about the cytokine release syndrome that has been very well described, and we will go in details in that. And you have the hypersensitivity and allergy with anaphylactic shock, asthma, contact dermatitis, but more specific like Stevens-Johnson syndrome and Rett syndrome, Lyell syndrome. And you have also hepatitis due to activation of the immune system. And you also, we can put in the immunotoxicology immunogenicity. Immunogenicity, when you have an immune reaction, for example, to a therapeutic antibody, neutralization of therapeutic activity, in some rare cases inducing anaphylaxis, and also in rare cases, you have immune complexes between an antibody that is used for treating rheumatoid arthritis, for example, and anti-TNF-alpha, combined with an antibodies to the antibodies. And also autoimmunity, that can be present in small molecules and also some biologic like lupus or bowel inflammation, autoimmune hepatitis. Let's start with immunosuppression. So with immunosuppression, the clinical consequences, infectious disease, certain types of cancer. Consequences of the downregulation of the immune response. First, that is coming from some results that has been there for more than 30 years. The observance of the incidence of cancer in kidney transplanted patients. Because the transplanted patients are highly immunosuppressed to tolerate the transplant, and they mostly receive, for example, cyclosporine A, corticoids, and also anti-metabolites. And you can see that the emergence of cancer, you can have skin cancer, okay, due to HSV1. So in this case, it is a virus. It is a virus, and it is 38% of cancer in this population. It is significantly higher than in normal population, and it is exposure to the sun augment the incidence because when you have a sunburn, for example, it is immunosuppressive when in the area when you have the sunburn. You have an augmentation of non-Hodgkin lymphoma due to the Epstein-Barr viruses, and again, it is immortalization mostly of B cells. Kaposi sarcoma with HSV8. In this case, it is very, very high incidence because Kaposi sarcoma has a very low incidence in normal population. And you have cervical cancer due to HPV-16. And so in this case, it is 15% of total cancer in this population in female. And it is a higher incidence because this cancer is prevalent in women, but not a very, very high incidence. So you can see when you follow this kidney transplanted patient, you can understand that immunosuppression in this case can provoke the augmentation of cancer in this population, significantly different than the normal population. And it also inducing the augmentation of infection, and I'm not going to go in great detail. And so immunosuppression has been is now has been marked as one of the key characteristics of carcinogens. And you have this publication from Martin Smith from California, and that has been published in our last perspective, which is all the key characteristics for a molecule to be a carcinogen. And you can see that the key characteristic 7 is immunosuppressive. It is clearly one of the key characteristics of the carcinogen. If one molecule can decrease immunosurveillance and induce immune system dysfunction, it can participate to a carcinogenic effect of this molecule. And recently, PFOR, which is an immunosuppressive drug in human, in animals, and in vitro model, is now classified as carcinogen to human, group 1 formally higher. Another example, which is Tisapri, the natalizumab, it has been shown after marketing of the drug. It is an antibody directed to an antigen, and its indication is multiple sclerosis. And after the drug has been on the market, there's been some cases of progressive multifocal encephalopathy. One death in patient receiving natalizumab and Avanette with interferon beta. Then you have the third case in clinical trial in Crohn's disease when you don't have any kind of interferon beta. And at the end, the drug had been stopped, so had been re-evaluated for this risk. And it was clear now that after 1 year of research, the company has been able to show that this PML was due to the reactivation of the joint-killing viruses. Meaning because you had the natalizumab, also it was decreasing the recruitment of autoreactive lymphocytes in the brain, but it was also inhibiting the recruitment of normal T lymphocytes and participate to immunosurveillance to viruses. So in this case, you diminish the recruitment of T cells in the brain to protect you after, to the reactivation of the joint-killing virus that is present in oligodendrocyte. And so in this case, you diminish immunosurveillance and you reactivate the GC virus that is infecting oligodendrocyte and you provoke inflammation. And in 2017, it has been finally calculated that the cumulative risk of PML with people with a positive GC virus serostatus is about 27 per mil if you have obviously immunosuppressed. And if you don't have immunosuppression, I'm sorry, the slide, won't show the slide, it's about 2% to 5% of the patient. So there is the target of immunosuppression very quickly when you have low molecular weight compound. It is mostly T-cell receptor sensitization. A good example is cyclosporine. Interleukin-2 sensitization. Good example is sirolimus. Alteration of lymphocyte trafficking with infligolimod that is used in multiple sclerosis. Inhibition of lymphocyte proliferation, of course, with all the compounds like azathioprine, cismacaptopurine, mycophenolate mofetil, methotrexate that are used as immunosuppressive drugs or as used in cancer. So if you have a compound that is targeting intracellular pathway that is known to participate to activation of the immune system, clearly is going to be a compound that's going to induce immunomodulation and immunosuppression. For the biologic, in this case, the targets are more extracellular. You have the anti-TNF-alpha, you have the anti-T cell receptors, the anti-cytokine signalization, the natalizumab is altering lymphocyte trafficking, and also the anti-CD20 that can provoke inhibit lymphocyte proliferation. So these two slides are here to make you understand that the target of compound that could be biologic or can be small molecules, there is many targets possible, but if you identify targets that are involved in signalization, involved in activation of T cell or activation of B cell or regulatory T cell, then you can affect the immune system. We have a guideline. So we will the ACH-S8 that is quite old now. There is a new guideline that has been now promoted by FDA, and I don't know if some of you are going to attend. There is a webinar for FDA at 7 p.m. for Central Europe today. And it is clear immunotoxicity is defined as an intended immunosuppression enhancement. And I'm not going to go in detail in this ACH-S8, but immunotoxicity related to immunosuppression is covered by ACH-S8. The issues with biologic is mostly covered with ACH-S6. And so ACH-S8 is using a weight-of evidence approach, meaning that, weight of evidence approach, if you have an idea that if your compound is altering histology or histology of immune organ in animals, for example, that's one of the weight of evidence approach. If your compound is belonging to a well-known class of compound provoking immunosuppression, that's also part of the parameters. But it is when you have your toxicology program conducted, it is you, the study director, that based on the results you are going to open, based on your molecule, you're going to build this weight of evidence approach that make you understand that maybe your compound could have some immunological effect. And then you will, if it is the case, then you will go further by testing the drug using more specific immune tests, immunotoxicity tests like the T-cell dependent assay. So to keep in mind, predicting infection and malignancies resulting from oncogenic viruses, it is clear that for immunosuppressive molecule affecting T-cell function, this is clear. But sometimes when you suppress some specific component like integrin and natalizumab, or if we affect trafficking of the cells like you can see in fingolimod, then you have an unexpected observation. We have a long time experience with compound that are affecting T cell function, we don't have that much experience, I'm sorry, with molecules that are affecting specific component of the immune system. And when you try to predict that using host-resistant animal model that sometimes are very sophisticated and very interesting, you identify the danger of the drug, okay? But you cannot say if you, for example, using a very nice model with influenza virus, it is not clear that if you have augment the influenza virus infection in your animal at a certain dose, it is clear that it means that your compound is going maybe to play a role in host resistance. But it doesn't mean that at the dose you're going to use in animal, it's going to be the case in human. So host-resistant animal models are very useful to identify the danger, but then to predict the risk, it's much more difficult. So let's go now to hypersensitivity. And so let's start with clinical manifestation, because it always starts with clinical manifestation in case of hypersensitivity. It's coming from the clinician. And all the basis, the rationale of hypersensitivity reaction is based on clinical observation. So on one side, it's on the right, you have non-allergic hypersensitivity. And in this case, it is the innate immune system that's going to be involved. And you have what we call pseudo-anaphylaxis. So in this case, it's not antigen-specific. It is that your compound can induce the release of histamine or prostaglandin and some other mediators that provoking some hypertension. And so with hypertension, you have some clinical symptoms that can mimic anaphylaxis. On the other case, you have the allergic class of hypersensitivity. In this case, you have adaptive immune system. You have T cells and B cells that are specific for your drugs or your chemical. And it can be IgE independent, and you know that it's type 1 hypersensitivity, which is mostly anaphylactic reaction that can provoke death in extreme situation. And you have non-IgE dependent allergic reaction. It can involve IgG, very specific, mostly with compounds that are involved in anesthesia. And you have CDL cells. So CDL cells can provoke immune-mediated hepatitis, or can provoke Stevens-Johnson syndrome, or can provoke TRES syndrome. In this case, these CDL cells can induce cytotoxicity on cells that are going to express molecules associated with class 1 HLA molecule. So the definition of allergy, it's a clinical manifestation with inappropriate immune response. And so the clinical manifestations are very diverse, okay, from systemic anaphylactic shock to allergic contact dermatitis, and to many different types of clinical manifestations affecting the skin, and you also asthma in the lung. So it often involves an immune response directed to the chemical. It is the Apten hypothesis, and we will go into a bit more details. And in this case, you have antibodies and lymphocytes that are recognizing the molecule. And in this presentation, I will not have the time to present you some other type of mechanisms like the PI concept or some other concept showing you that in sometimes drugs can activate the immune system without being recognized specifically by antibodies or T cells. But in a general schema, you have two phases when concerning allergy to small molecules or to big molecules. You have the sensitization phase. There is no clinical manifestation. It is dose dependent. You are immunized. For example, you apply on your skin some methyl isothiazolinone, for example, that is used as a conservative sometimes in cosmetic and some other products. If you apply on the skin, then you have allergic contact dermatitis. Okay, this is the clinical manifestation. But most of the time, you can be sensitized. You can have cells that are recognizing this methyl isothiazolinone, but you have no clinical manifestation. The same with nickel. Sometimes you are immunized to nickel, but you're not allergic. So understand that the elicitation phase, when you have the clinical manifestation, it's a small percentage of the people that are immunized to chemical. So I'm going to skip this slide for a question of time. I'm sorry. And so this is all the clinical manifestation can have. Urticaria, which is quite mild. You have CD4 cells with IgE. And you have all these red spots is because you have augmentation of the endothelial permeabilization. Angioedema, you have a specific edema of the face, which you can see here the edema on the lips. You have very severe, in this case, it's involving CD8 cells. You can see all these spots, the red spot, and after you can see that all these red spots are joining on the thorax of this person, and it is due to the lysis of keratinocytes. In this case, keratinocytes that are expressing the molecule through Clash1 molecule, like a viruses, for example. And so the CD8 molecules that are specific for the drug are lysing the keratinocyte, and then you have all these red spots corresponding to the lysis of keratinocyte. And then you can affect, for example, the skin barrier, and when it is very severe, you can affect up to 30% of the skin barrier. Allergic contact dermatitis, you can see it here in the middle with a nickel, because it's part of the bottom of the gene. You can have allergic contact dermatitis to a product that are anti-fungus on shoes. And here on the left, you can you apply a cream and you can see that you're allergic to the cream. And what is interesting is the fact that you have this clinical manifestation. You see here the bullous erythema. You can see also the macular exanthema. You can see the pustulosis on the right. And you can see, if you go on the slide at the bottom of all the pictures, you can see that it is corresponding to a specific immune activation. You can see here, you can see there is CD8 cells here in the skin. Here in this case, you have CD4 cells that are secreting interleukin-5. And here in this case, you have CD4 cells, CD8 cells, and you have interleukin-8 that is secreted, recruiting neutrophil and provoking this the emergence of this vesicle. So you don't know why, in this case, this patient is going to make a bullous erythema, or this patient is going to make a pustulosis. You don't know. Sometimes with the same molecules, you can have bullous erythema in some cases, pustulosis in some other cases, macular papular exanthema in some different cases. So we don't know. But what we know is that each clinical manifestation is linked to a specific immune reaction involving different types of immune cells. So the clinical outcomes are mediated by different immune physiological pseudopathological mechanisms. And so this is the basis of the Gell and Coombs classification of hypersensitivity reaction that has been modified by different authors. So the type 1, you can see it is allergic rhinitis, asthma, systemic anaphylaxis. We know the cells, mast cells, that are secreting histamine, for example, also other mediators, and we know the mediators that can be IgE. Type 2 is more cytotoxicity of the cells. Type 3 is immune complex formation. And now we have divided for the type 4 that's involving cells, because you can see type 1, I'm sorry. Type 1, type 2, type 3 are involving antibodies. But type 4A, type 4B, type 4C, and type 4D are involving cells. And before, a long time ago, when Gell and Coombs decided to classify the hypersensitive reaction in 4 types, you have only the type 4. But we know, especially when you are dealing with drugs and small chemicals, then you have different type of clinical manifestation in the skin. You have contact dermatitis, you have macular papular exanthema, you have chronic allergic rhinitis, you have bullous exanthema, and then you have also the pustulosis. And so each time you can see, if you are in type 4A, you have this contact dermatitis, okay? And you have chemokine secretion, and you have inflammation, you have macrophage activation, and you know that Th1 cells are involved. So for the 4B, we know that you have macular papular exanthema with eosinophil present in the skin, for example. We have chronic asthma or allergic rhinitis. And we know, in this case, you have some T cells that are producing cytokines that are involved in the recruitment of eosinophil. For the type 4C, you have, for example, contact dermatitis, so you have bullous exanthema, you have hepatitis, and in this case, you are killing the cell. You have a strong CD8 CD8 cell activation, and in this case, you are killing the cell, like the Stevens-Johnson syndrome, for example. And in the case of pustulosis, so in this case, you have more interleukin-8 that is produced. So the message here is that hypersensitivity reaction there's multiple types of clinical manifestation, but each time you have a specific immune reaction that is present under that. What is really unknown is why a patient is going to do a 4A and one time and the 4C another time, different patient, and why people get sensitized, that we could understand how people get sensitized and get immunized, but we don't know how the people that are immunized then have an allergic reaction. We don't know. We think it is the balance between regulatory T cells and effector T cells, but what kind of event can lead to the switching of immunization to allergic reaction is very, very unknown. So necessary step for the APTEN reaction, okay, your compound needs to bind on self-protein. Binding on self-protein means it is becoming an antigen. At the same time, your compound, in a way or another, it is really clearly defined for contact dermatitis, has to induce the migration and maturation of dendritic cells. In contact dermatitis, for example, nickel, for example, nickel is an agonist of a toll-like receptor called TLR4. It can promote dendritic cell migration. Has to be recognized by the immune system. It means you need to have T cells that are recognizing your drugs or your chemical. And we know that we're not fabricating T cells that are going to recognize a dinitrochlorobenzene or nickel, etc. It means that the chemicals are able to bind to protein and to create some new peptides that are going to be recognized by T cell receptors that are normally present here to recognize some viruses or some other foreign antigen. Those who are squeezing in some way the immune system. And then you have, in this, you're going to be immunized. And then you have to switch to the immunotoxicological reaction, probably by affecting the balance between regulatory T cells and effector T cells. HLA association sometimes exists. It is not always, it is really clear for some compounds like abacavir, carbamazepine, allopurinol, glucosylceline, that we know they are associated with HLA molecule, because these compounds are very specific. The mechanism, I'm not going to go in detail, are mostly involved the PI concept. If you have a compound that is binding strongly to protein, meaning that you're going to generate many peptides that are different with your compound bound on it, meaning that you can bind on many actually HLA molecules from different people, meaning in this case you don't have any kind of HLA restriction. When you take the drug that the most allergic chemical drugs is the beta-lactam family. Beta-lactam are highly binding on albumin, so lysine. Okay, so in this case you don't have HLA restriction in the population, meaning that a lot of people are allergic because there's many peptides produced and many peptides are binding the penicillin. So there is a recruitment of very different HLA molecules, and so very different people. So the hypersensitivity is a combination of chemistry, pharmacology, patient factor, immunology. Okay, and so it is important to keep that in mind. So you understand in resume, for a question of time, we're going to go a little bit faster because we started a little bit late. So now, inappropriate stimulation of the immune system. Cytokine release syndrome. We have multiple examples. Anti-CD3 in 1988. Anti-CD52 adalimumab treating leukemia. Anti-CD20 rituximab to treat lymphoma. TGN-1412, I'm going to be very quickly in this example. Some new molecule, inatumomab, which is anti-CD19 to recognize lymphoma, and anti-CD3 to recruit T cells that are going to kill your lymphoma cells. Bispecific, all the bispecific antibodies that have an anti-CD3 arm. What is anti-CD3? Anti-CD3 is a molecule that expresses on T cells. So if you recruit T cell by activating CD3, then you're going to activate your T cell. And of course, you have the CAR T cell, the chimeric antigen receptor T cell, that can also induce cytokine release syndrome. So the TGN-1412 story, very quickly, it's a phase 1 clinical trial. The potential therapeutic condition was autoimmune disease. 6 human volunteers received the product, very low dose, and you have a major cytokine release syndrome. And it was an antibody directed to CD28, which is a co-stimulatory molecule. But what is very tricky with this molecule, you can bind to CD28 and you can activate T cell without having any kind of antigen. So you binding CD28, you induce proliferation of your cells. And the idea here behind was to mostly induce the proliferation of regulatory T cell to fight autoimmune disease. So it means that this is not a mechanism that is naturally existing in the body. Okay. So if it's not a natural mechanism, you don't have counteracting natural mechanism. And what happened? Severe cytokine release syndrome. You can see you inject your TGN-1412, and after you have all the patients undergo multi-organ failure. For this patient 6, from 12 hours to 15 days. So all these volunteers went to intensive care. So you can see here a patient with necrosis of the fingers, and you can see here also a patient with some necrosis where they have the catheter. And the cytokine are here. You can see the quantity of TNF-alpha. You have 5,000 picograms per ml TNF-alpha produced, which is corresponding to a septic shock. So you can understand why these patients were all very severely affected. And the mechanism is still putative, but probably the mechanism is that you inject your TGN-1412. It is binding to FC receptor or the antibodies endothelial cells. Then the antibodies quickly recruit T cells that are probably what we call effector memory cells that are here to rapidly answer to an infection. So effector memory cells that are present in lung, in skin, and so very rapidly activated and release a lot of cytokine because its effector memory T cells are here to defend you very quickly. So one thing that you have to understand, I'm sorry to go to a bit maybe too fast, is that the toxicity didn't predict this effect. Okay, the TGN-1412 was recognizing very nicely the CD28 on monkey, but it didn't work because there is no CD28 expressed on effector memory T cells in the monkey. So we have this new AMA guideline. I'm sure you're aware of it. And there has been now a revision that has been published 4 years ago. And it is now the concept of using the MABEL, the minimal anticipated biological effect level, versus no NOAEL in certain conditions. Immunogenicity. Immunogenicity is when you have an immune reaction to the therapeutic product, okay? And you have neutralization of the biological activity. You can have some allergic reaction, and you have a loss of clinical response. So very quickly, when you inject a compound, you can induce immunization to this compound. Okay, we already saw that with the hypersensitivity. So in this case, it's mostly focused on the biologics. You can have a break in immune tolerance, and that has been shown for EPO. Okay, erythropoietin, that you inject EPO in certain conditions, and then you break immune tolerance. And by breaking immune tolerance, you can induce immunization to endogenous compound, which is different from hypersensitivity reaction, which is a foreign compound. This is the case of EPO. You did modify the formulation of EPO at that time, and then you have the emergence of pure red cell aplasia. You can see it, and it was due to the presence of antibodies. This is an in vitro assay, and when you put the patient serum, you can see there is no more colonies that can red blood cell colonies, I'm sorry, that are because you have this patient serum that is neutralizing erythropoietin due to the presence of antibodies to it. This is a good, EPO was a good example. It means that you have to be very, very careful in certain conditions when you inject an endogenous compound, for example, in this case for EPO, or it can be interferon beta, for example, for multiple sclerosis. You can break the immune tolerance if you change formulation, if you have aggregates, for example. Another good example is cetuximab. Cetuximab, it's an antibody directed to EGFR, the receptor for EGF to treat, for example, breast carcinoma. And they found that at the first time of injection, you have a high prevalence of hypersensitive reaction in this patient. And when you go back to this patient, what you find in this patient, they have antibodies, IgE antibodies directed to cetuximab. But okay, they have anaphylactic reaction. Of course, they have antibodies directed to cetuximab. But at the same time, when you take other people that have not been injected to cetuximab, they also have antibodies recognizing IgE recognizing cetuximab. So in this case, what does that mean? Does that mean that the people have been immunized to cetuximab without cetuximab? It means that you have to probably these people have been immunized to a compound that is cross-reacting with cetuximab. So again, and this has been proven, it is proven that this IgE was directed to a glycosylation site, the galactose alpha-1,3 galactose. And it means that these people have been immunized to this specific glycosylation site, provoking the reaction hypersensitivity to cetuximab. So the take-home message here is what? Take-home message is, be careful when you inject a new drug, a new compound. You can have your patient can be immunized to some of the components you didn't think about. Okay? They're pre-immunized. So now cetuximab is produced using different cell lines, and you don't have anymore, you don't have this glycosylation site anymore present on antibodies. Then to finish, the last effect, autoimmunity or immune-related effect on target organ. And it is concerning all the products that are affecting this immunological synapse, ipilimumab, nivolumab, all these products involved in immunotherapy. The best one is anti-CTLA-4, okay, Yervoy, the ipilimumab, that is blocking CTLA-4 to reactivating T cells that are present in tumors. Okay. But the consequences, of course, you're going to reactivate your anti-tumor T cells in your tumor, but you're going to reactivate all the other T cells. And so what you found, you found diarrhea, okay? And what is curious in this case is that you're reactivating T cells, okay? It's working very well in terms of immunotherapy, immune checkpoint inhibitor. But while we are reactivating T cells that provoke inflammation in the digestive tract, this is not very well known. And it is not very well understood. It's very important to understand. It is the case also for anti-PD-1 or anti-PD-L1. You have an augmentation of skin-related, GI, endocrine, hepatic effect at mostly grade 3 to 4, but very, very few patients. But then why? Nivolumab is increasing thyroiditis. Okay, why it is inducing some skin-related effect? So we don't know why. And some patients are having some hepatic effect. Some patients having more endocrine. So I'm going to quit the screen. I'm sorry because I'm a little late, and go to the conclusion. So what the conclusion on immunotoxicology we can have, and as a toxicologist. First, so you understand you have different types of clinical symptoms. How to predict it. So we have to ask questions. Are the experimental models appropriate to detect immunosuppression? We can identify danger, clearly. How can we analyze the risk? For PFOA, for example, it's a very interesting model because PFOA, there's many clinical studies showing that PFOA can affect vaccination in patients. So in case you have evidence in animal model, but you have also evidence in human. This is very rare. Are the current animal and in vitro model predictive of the potential outcome in clinic? How to evaluate long-term effect of immunomodulation? How to have good experimental model to develop for detecting drugs provoking systemic reaction, like anaphylaxis. The same for detecting DILI, TRESS syndrome, or toxidermia provoked by small molecules. And also, we have a very nice assay to look at drug-induced cytokine release in vitro, but what are the transposition in the clinic in terms of dose, in terms of prediction? So why I'm using this type of conclusion, it's not a resume of what I've just said. It is just to show you that we have many, we still have a lot of work to have some models that can predict what can happen on the immune system, either immunosuppression, hypersensitivity, or some kind of autoimmunity induced by immune checkpoint inhibitor. But we are more and more understanding what is happening in human, especially when you are using these immunomodulatory drugs, the immune checkpoint inhibitor. So thank you very much for your attention. It's been a bit long, but I hope you have questions.
Marc, thank you very much for your very nice in-deep overview of the immunotoxicity and the different possible adverse effects and way to address. We will indeed have 2 questions from the participants. So I will start with the first one that actually is linked to the last point of your conclusion. And because, I mean, it's related to the cytokine storm and the in vitro opportunity and the methods that we have. And so the question is, if you could comment on the factor that in the red, the identification of a cytokine release storm in human peripheral blood mononuclear cells. This was concerning the case of the T-Genero TG1412, but maybe we can also extend.
So the question is to make some comments on that. Okay, so
yeah,
I mean, it can, for the T-1412 is a very specific story because no one did predict it. Okay, because the animal model at that time when the T-1412 was developed, these antibodies was not really a concern in terms of safety. Okay, and so when the TNG1412, and we thought that when you have a good animal model, and when you can have the molecular target, it was recognized by the antibody in animal, it was sufficient to have the animal that could be predictive. And the TNG1412, the big lesson is that no, even if your antibodies is recognizing your target in animal, it's not sufficient for your animal to be predictive. Okay, it is not sufficient at all. You need to understand where your molecule is expressed, and you have to compare between animals and human if the molecule is expressed on the same cells, and also if the molecule is affected is also involved in the same kind of mechanism between animal and human, and also if you also mimic the pharmacological effect in your animals. And that is really the lesson of TGN1412, because when you inject 50 milligrams per kilo in monkeys, you have no effect at all. Even if TGN1412 is binding quite nicely to the CD28 on the monkey, but not on effect on memory cell.
So it's clear, I mean, like a biotechnological or biologicals are really a challenge overall in toxicology, not just for yes, the immunotoxicity.
Right. But if you understand the mechanism of action very well, then you can predict some effect.
Yeah. Okay. So in a sense, also the other, the other question is related to, I will take the last question that we have, and then I will go back to the question from Christian Blott. Because the last question from FAM is asking, what are your recommendations for different approach in immunotox when you test biologicals and traditional low molecular weight pharmaceuticals?
Okay, so for the low molecular weight molecules, well, that's a very good question. Because if you do low molecular weight molecules, okay, then you don't know the target. Okay, you know the target for the biological activity, but you don't know other targets. So, and you know it's going to be distributed in many organs. So you do your animal studies, okay, and then you have some effect. And so the ESA guideline tell you that the weight of evidence approach will tell you by affecting histology, affecting the enumeration of the red blood cell, etc., etc. It will tell you give you some ideas if you have to go for further testing. But okay, that's for low molecular weight. But in this case, you are missing, it is clear that you are missing some drugs that are not affecting really histology, but can affect in a more specific way the immune system by inhibiting lymphocyte proliferation. But clearly, animal models are useful in this case for immunosuppression. If you test a biologic, it is mostly related to the mechanism of action. The type of target you're going to have of your immune system, if it's an anti-CD3, if it's an anti-TNF, if it's an agonist, an antagonist, and you can predict many kind of effect due to the knowledge of the target. That this is clear. But now, if you go back to low molecular weight, for example, to predict hypersensitivity, this is not possible today. I mean, of course, if you have a compound is highly binding on protein, then you can maybe understand it can be reactive, it can be an APTEN mechanism. So if you know if your drug is binding to protein, if your drug can induce inflammation or can activate dendritic cells, if your drug is an agonist of TLR molecule, TLR receptor molecule. So if you have some characteristic of this molecule can make you think that it can induce allergic reaction. But again, traditional models are not very useful for this kind of reaction. You need to go back to the understanding of the molecule, the understanding of the mechanism of action of the molecule.
Yeah, thank you. I think that you made a very good point. Now, the question from Christian. With increase in knowledge in this field, meaning like also immunology in general, including current scientific approach and regulatory guidelines recommendation, can we say the gap between findings in non-clinical studies and post-marketing surveillance has diminished? Meaning, with the increased knowledge, have we actually reduced the adverse effect related mainly to drugs on the immune system?
I would say that, for biologic, we progress a lot, okay? For cytokine release syndrome, we progress a lot by looking at the mechanism of action. We can anticipate there will be cytokine release syndrome. And now the clinical teams are more and more educated to treat cytokine release syndrome, to mitigate the cytokine release syndrome. If you go back to small molecules, so for hypersensitivity, even if we know a lot more in terms of mechanism of allergy, what is lacking is of course more research to understand what is drug allergy, what kind of patient, etc. But what the progress that has been made, I must say, has been on allergic contact dermatitis. Because for allergic contact dermatitis, a lot of research has been made. We know the mechanism. We know that it's mostly mediated by drugs that are binding on protein. And now we have in vitro assay can predict the danger of the molecule. For allergic contact dermatitis, it is very interesting because a lot of research has been in it. And so it's by understanding how it is working that we have been able to develop in vitro tests. For immunosuppression, it's an issue. It's an issue because there is some nice model that's been developed with monkeys that are infected with CMV, for example. But still, we don't know if 30% reduction of NK cell activity will translate in a high risk of infectious disease in human and cancer. It's only when you go back to human that are immunosuppressed, and if you very deeply analyze what is immune response in this patient, that maybe you could predict better. Okay, but again, this is not done. It is done for immune checkpoint inhibitor, but for immunosuppressive drug, we don't know. There's very few publications going deeply on an understanding of the immune response in this patient. PFOA is an example. PFOA is a very good example because it's on the contrary. PFOA, you have very nice research work, and you know that, Emanuela. Some of them is coming from your team. and you have evidence in the population. So we can reconcile what is happening in population, decrease of vaccination, for example, augmentation of upper respiratory tract infection, related to what we found in animals and what we found in an experimental model. So you can relate the decrease of the immune response in animals to what happened to humans. But it's a very, very single example for me. Very few compounds have been so well studied.
Yeah. Okay, yes, so this is a good point. The other point that Christian was actually mentioned is like, do you think that the new FDA finalized guidelines for immunotoxicity is a plus over what already exists?
So I'm sorry, Christian, but I cannot answer this question because I didn't have the time to go deeply on the FDA guideline. But I'm going to assist to the webinar at 7 p.m. today that is given by FDA to make us understand the immunotox guideline. So I'm sorry, Christian, but if you send me an email tomorrow, I can tell you more.
More if it's an added value. Yeah, because I also have a question related to that. So, I mean, how can we improve? Like, we have routine tox testing. And for drugs, for chemicals, so we do on a case by case. So if we have indication of potential like immunotoxicity, mainly immunosuppression, then we go on a case by case within in-depth studies. So we had a few years ago a discussion, okay, if I have to use animals, what can I do to get more information on the potential immunotoxicity with not doing the TDAR, okay? Because, I mean, there is still quite a lot of reluctancy in using like an activation of the immune system sort with the antigen, because then you can modify. In reality, if you do the IV, you only modify the spleen. So, but it's not, even if this was demonstrated that you can still use, so every time you do the TDAR, you have a satellite group of animals. But there are many of the assays that are available that, I mean, you do ex vivo. So you take, in animals, we use the spleen, or we take additional parameters from the blood analysis. What is your suggestion for like to improve, to add additional immunotox or immunological relevant endpoints in current routine toxicological testing in animals?
I must say, I don't have a lot of suggestions because for immunosuppression, again, immunosuppression is really related to the adaptive immune system. Of course, we can have with now the new technique in flow cytometry, etc. You can look more deeply in lymphocyte population as we do in patients, for example. So I don't know if using very sophisticated flow cytometry technique would really improve the detection of immunosuppressive drugs, because we know that immunosuppressive drugs are really detected when we can detect the affective immune response, the adaptive immune response. Okay, well, of course, if we decrease natural killer cells, we decrease this, or decrease that. Yes, we can do a better immunophenotyping of the animals. That this is clear, and that we can give us some idea on what kind of subpopulation can be affected. But again, we are missing a very simple assay to see if your compound is affecting the activation of T cell or B cell. We can do it in vitro, of course, but we're not going to impose this kind of assay to every kind of molecule that's going to be developed. Okay. So I don't have really a very striking new suggestion. Okay. And we are still at the same point. We are still at the same point. If it's really based on mechanism of action. If you during your profiling of receptors, maybe we could increase the profiling of receptor, including more targets that are involved in immune system activation. That could be an issue when you go in a very early step of your development. If you increase the panel of molecules that are tested with your molecule, that probably will improve a little bit more what can be the effect of your compound immune system.
Yeah, you know, the reason for which I ask this question, because we still rely on histopathological changes.
Yeah.
And histopathology, beside being subjective, is also not very sensitive. And so the question, because I mean, I've been like involved in the BPA opinion where, as you mentioned, interleukin-7 change in TL+17 was identified as a critical endpoint. We got a lot of criticism for the using of these endpoint, because you know, when you go in risk assessment, the immune system is not well seen. So they prefer actually not to do anything. But it's not that not looking at the data, then you have started to have problems in the general population. So which means that we failed in the preclinical evaluation to identify the potential hazard for the population. So that's why, I mean, can we find a way? Because I mean, if you use the animals, why not to do more? I know that this may require to be like a cost, maybe a time, because you need to implement methods within the CRO, but maybe then we can predict and have a better safe use of chemicals. So this was my why I ask you this question. But now we have one more question that since we are talking every day on artificial intelligence, so the question is there any artificial intelligence system that enables the identification or prediction of immunotoxicology?
Not yet, but I mean, artificial intelligence in biology is based on a signaling pathway network. So again, I think with small molecules, if we more deeply analyze what could be the target, the possible target of your molecules related to immune system, off target, for example. Again, it goes back to what I said before. If you can increase the panel of molecules, you're going to be screened with your low molecular weight. If you increase your panel with immune-related target, for example, if you include, for example, calcineurin A, if you can include PKC, some target in your panel, probably you will increase the predictivity you increase predicting immunotoxicity with like a weight evidence approach. And if you have several targets are involved, then you can start to create an artificial intelligence way of looking at things by looking at the simulation network, because everything is based on mechanism of action. So danger identification based on looking at a receptor or signaling pathway target related to the immune system would really improve the predictivity, I'm sure, because then you can set up in vitro assay. And then you go to animal model if you need it.
Yeah, and then also, like, if you think the current and the upcoming adverse outcome pathway for addressing the different aspect of immunotoxicity, then of course you can think a way to use the artificial intelligence to connect all the system together. One thing that fascinated me is that we have a computational model that mimic the immune response, because as you said, I mean, it's based on a network of cells, of mediators. And so since we have starting to have a better and better understanding on the immune system, so they also transpose this knowledge in a computational modeling. So,
I agree with you, Emmanuel. If you have a computational model of the T-cell activation, which already exists, if you know that your molecule is interacting with that target, then you can play with your artificial intelligence. Of course, that's clear. So
this is definitely. So, I mean, what I have, I think that we do not have any other question unless, I mean, the only one is if we can add, but I'm sure that Hélène, she will send the link when, and also when the webinar will be made available on the EUROTOX website. So you will get an email when the presentation will be uploaded and made available to you all. And definitely, I mean, really, I mean, Marc, thank you. And this, I hope, will be just the start, because, I mean, you scratch all the possible, like, immunotox, the animal models, but then we can really, like, think of more in deep webinar addressing chemicals, drugs, in vitro methods. So there are many underlying mechanisms. So we can think really to cover. We try to be very good within the EUROTOX Congress to put a symposium workshop on immunotoxicity. But definitely also here I see many possible additional webinar just staying on the immunotoxicity. So I believe because I'm just so we have like many people thank you, Marc, for the nice presentation. So I don't see and so I mean there's also someone that say, okay, so I wanted to know more like let's say like a detail or less more detail webinar on immunotoxicity. So I believe that
there will be more webinar on the very detailed webinar on different aspects of toxicology in the future. Yeah.
In the future, and then also
webinar, and then we will have more specific webinar.
Yeah. So this is the strategy. So at EUROTOX, basically we just started with this idea within the education subcommittee. So saying that, once again, thank you all for the participation, and thank Marc for the wonderful presentation you gave us. So
thank you very much, Manuela, and thank you for the attendees to take some time.
Okay, so enjoy the rest of your day. Thank you.
Thank you. Bye-bye.